Yes, hello everyone. I think everyone has a uh, maybe a little bit experience, maybe more experience, medium, and maybe they are advanced on the cardiac scan. But before the cardiac scan, I believe that we should know some cardiac anatomy. If you don't know cardiac anatomy, it's not easy to get the good image quality without motion images because everyone knows the heart is moving and we cannot stop the heart. Any machine, any speed cannot stop the heart. In this case, and what we are doing, we are using some softwares and we are using the high rotation speed, the high temporal resolution, and to get the without motion images from the heart. Also, heart vessel is, as you know, when we are trying to get the good image quality from the 1 millimeter diameter thickness in the vessel. In this case, and we should provide the best conditions and then we should go to scan. But the first things we should know, and before the acquisition, we should know some basic anatomy information about the heart. Okay, let me start. As you see that this is the 3D images for the heart. You can see some vessels and big vessels and small vessels. And small vessels, all they are cardiac artery and the cardiac venous system. And then let's go. And of course, this is 3D images. And there is a heart orientation, as you know. Heart is not showing as you see on the screen. It is the oblique. And it is oblique a little bit having a position on the left side. And because of this, the cross-sectional, the axial images, it is not showing like this. It is totally different. Before the acquisition, and then you will have this images only. This is only AP scanogram, anterior, posterior, and lateral scanogram. If you don't know where is the heart, and you cannot scan the cardiac very easily, during the scan and before the scan, you should adjust your scan range. If you don't adjust, if you careful about the positioning and of the patient also scan range, you will cut the heart and then most probably you will repeat the acquisition. This is the reason, but I'm not telling you you should scan the big range because on the cardiac acquisition, when you go to the ECG gating scan, every rotation increasing the dose. This is the reason we should scan and possible small area and to decrease the heart. If you ask me how much dose increasing on the cardiac, dose is increasing if you compare with the chest acquisition and cardiac acquisition, dose is going to minimum double or triple. And it depends of the patient size. When you have these images, you can see my mouse most probably. And here, and heart is in the middle, little bit oblique on the left side. Everyone knows. But on the lateral, also, it is in the front side, okay? And when we talk about the isocenter of the machine in the gantry, we have to keep the middle of the heart in the isocenter to get the best image quality because the less angulated the photons coming to the in the middle. Okay. And don't forget, we never exceed cardiac acquisition, yani heart vessels will never go upper part of the carina. Carina is here, and the trachea it's coming and then dividing two parts, and then this is carina. And you should start from carina, and you will come until end of the heart. It is the heart border here, and then you will exceed the maximum 1 or 1.5 centimeters. And also, let me show you the another images. This is our coverage region. This is the green line. It is showing the standard cardiac acquisition. And then when you cover from upper part is covered from the carina and little bit below of the heart border, and then you will never cut the heart. And this is the anatomy, heart anatomy on the 2D images. Also here you can see that you will never cut here and then always keep your rectangular in the front, because heart is, as I said, heart is in the front. What is the another blue line? Blue line is when you are going to do CABG acquisition, bypass acquisition, and then you should cover the bigger area. You should start from the above of the left subclavian arteries until the 1 centimeter, 1.5 centimeter below the heart border again. It means this is full chest acquisition, and also field of view will be bigger than the cardiac acquisition. Cardiac acquisition will take maximum 14 centimeters, and the CABG acquisition will take around 30 centimeters maximum. Okay, this is the anterior posterior view. This is your scan range, and this is here. It is on the lateral images, and this one is cardiac routine, and another one is the CABG. Okay, and what is this sure view location? It is the localizer. It calls bolus tracking. It calls, some of the company calls smart prep, and some of the company as sure view location. And you can keep in the middle, and also you can keep in the carina level. If you have the 4 centimeter detector system, most of the site hospitals, they are keeping on the carina level and as a localizer, and you can keep the ROI on the ascending aorta or descending aorta. Always we prefer the descending aorta. Why? Because there is no motion on the descending aorta. And also, when you see the contrast enhancement in the descending aorta, for example, 200 Huntsville unit, which means is the same level of the heart, there is a 200 Huntsville unit in the cardiac vessel. If you keep in the middle and here, and when you see the contrast in the descending aorta, 200 Huntsville unit, which means is the middle of the coronary arteries, there is 200 Huntsville unit. After the localizer, and mostly we will have the additional delay time, which is around 3-4 seconds, and we will start the acquisition later on. And this will provide us the enough scan range and then enough area to get the cardiac vessel information and a cardiac anatomy as well. Don't forget, the cardiac is giving the full anatomy information, not only cardiac, around of the cardiac, and also it is showing it depends of your field of view, scan field of view. Also, it is showing the lung tissue. It is giving the full information. Okay, let's go to next. And what is the name of the vessel? There is some main vessels, and which we know left main arteries, and LAD, left anterior descending arteries, and left circumflex arteries, left marginal obtuse marginal branch, and the RCA, right coronary arteries, and posterior descending artery. And there is one more artery, it calls PLB. And there is one more artery on the right side, also acute marginal. And there is some additional small arteries. It calls sinoatrial node, conus arteries. Also on the left side, there is a ramus intermedius, this additional small arteries. But we are mostly looking on these big arteries to go to any treatment if there is needed. Okay, and this slide is starting with on the left side, it is showing the without contrast. Right side is showing the with contrast images. We can know, and we know the ascending aorta, pulmonary arteries. Many people, they knows what is this. This is the biggest arteries in the chest region, and also there is a descending aorta. And what is the second important thing, especially for the contrast follow-up, and this is superior vena cava, SVC. It is coming next to aorta. When we give the contrast, we have to be careful. The contrast enhancement, it is coming around 2000 in the superior vena cava, because this is pure contrast. Pure contrast is giving the artifact because of the very high enhancement effect, too much absorption of the X-ray. And this is the reason you will see some artifact which is coming from SVC to the ascending aorta. This is the reason. And on this part, when we use it as a bolus tracking localizer, we prefer to put the ROI on the descending aorta, not ascending aorta. Ascending aorta affecting from the artifact which is coming from the superior vena cava. Which is very important. I will go down one by one. Okay, superior vena cava, ascending, pulmonary, and all are same. You can see here some black area. It is causing some artifact. When the contrast reach more volume of the contrast, when it reach the SVC, the too much artifact is coming to the ascending aorta. And also you should know this is the real scan. During the bolus tracking scan, because of the low MA, there will be more artifact. Okay, I'm going down. You can see the streak artifact. It is coming. It is coming more wide, and then it is giving the Hansville unit, increase the high Hansville unit in the aorta, and then it is starting early. We have to be careful on that part. And when you see the white color here on the LAD here, it is the calcium, because there is no contrast. Any white means is the calcium. And when you see the contrast and calcium, you can see the contrast differentiation between the calcium and vessel and the contrast, because the calcium enhancement is very high, mostly more than 700, 800, sometimes more than 1,000. And the contrast Hansville unit will never exceed the 700, maximum 750 maybe. It depends on the kVp. When we go to the low kVp, enhancement is increasing. And when you go to the high kVp, enhancement is decreasing. We have to be careful about the kVp selection as well. And here is we can continue the ascending aorta again. LAD is here, left main artery is here, and this is the left obtuse marginal. And there is some additional vessel. I will talk about this one later, not now. This is not arteries. And when I go down, next images, CX is coming. And left main is coming, dividing two parts, and the CX is generating, which is living from the CX. And the first vessel, it calls obtuse marginal. On this case, it is very early obtuse marginal, it calls. Some people, they are calling this kind of images as ramus intermedius, but this is not ramus. This is the left obtuse marginal. There will be many obtuse marginal. It will be 4, 5, 6, and it's not able to see in the cardiac CT because of the spatial resolution limitation. And you can see everything in the catheter angio, not in CT. In CT, we can show minimum 0.2, 0.15 millimeter thickness diameter, and in the CT systems because of the limitation of the spatial resolution. And also, let's go continue down. LAD is running. CX is going to the posterior. Obtuse marginal is going to the lateral part of the myocardium. And there is no right coronary. We are waiting for that one. It will come. And the next one, LAD, pulmonary artery trunk, left atrium, left marginal branch, and CX, it is here. It is going to the posterior part. Posterior is here, and you will see that this is the lateral, little bit posterior lateral, and also LAD is always living on the anterior part of the heart. And now, and we will see right coronary, it's coming. Okay, you can see here, SVC is very dense. And when I see this kind of images, I always says, we give them more contrast. It is not necessary. And you should not exceed some level of the contrast. When you give the 100 ml contrast, for example, with the 4 centimeter detector system, it's too much. You should not exceed the 80 ml contrast. And the 80 ml contrast, also you will see some SVC artifact. I prefer always and around 70, 75 maximum contrast or mixed contrast I am sending as a second phase. Okay, and LAD is living and moving on the anterior again. Marginal branch, as you see here, it is going to the lateral part, and the CX is going to the posterior part. This is cross-sectional and oblique images. Don't forget, please. This is very important. This is not real cross-sectional for the heart position, vessel position. And the heart and all the vessels, it is normally, it should be circle. As you see here, it is not circle. It is oblique images. Now, and let's move. And CX is still moving. And there is one more vessel. It is venous. It is not arteries. And the marginal branch here, LAD is here. And there is very small myocardial bridging. And this there is another small vessel. It calls diagonal vessels, which is living from the LAD. LAD is left anterior descending arteries. Let me remind again. Okay, left marginal again. CX is here, but it's not easy to understand here where is the CX because there is no contrast. And you can see here in the one of the calcium in the aortic valve. And this is the ascending aorta, but the very close part of the aortic arch, aortic valve. And right atrium is starting from here. Because of the oblique position, it's not showing at the same time. And later on the post-processing, we are going to keep in the show both atrium and ventricle at the same time. It goes 4-chamber, 2-chamber, 3-chamber, and we can show the aortic valve and different oblique levels. And the left atrium is, as you see here, left ventricle here, and there is no right ventricle as well. It will come later. And the right atrium, and finally we see here RCA, and RCA on the right side as well, living from the anterior part a little bit, and then going to the lateral part of the atrium and ventricle, and then going until the apex part. And the left ventricle, we see here again, atrium, and the CX is running, and here left marginal branch, and then right ventricle, and let's go down, and it is still coming similar. Right atrium, we can see better, and the right atrium again. Finally, we saw some contrast on the left ventricle, and the right ventricle also there is some contrast here, and the right atrium, right ventricle, left atrium, CX is, as you see the small images, when you see the small CX, mostly, and we can call it the right dominant system. Because if the CX is very big on the left side and coming to the right side, it will come to right side as well if it is big vessel, which means it's the left dominant system. If the RCA, it is big like this, and we can call it the right dominant system. On this patient, it is right dominant system. This is normal anatomy, and this is not abnormal anatomy. And we can see all the vessels one by one. And you can follow here, again, LCX, marginal, and here it goes ventricular groove between the right ventricle and left ventricle. Always LAD is traveling to the apex, through the apex part. And the RCA, and finally aortic valve is here, and RCA is running. Some small vessels living from RCA, it goes and conus artery and lateral ventricular branch. There is many branch, not only one. And also CX is running, as you see here, on the posterior and the lateral part, and marginal branch. Marginal branch will be more than one, and the diagonal vessel will be more than 3, and also lateral ventricular branch, including the acute marginal, will be more than 3. It depends of the size we can show on the CT system. This is the conus branch, which is living from the RCA, as you see that. We are calling this one as a sometimes lateral ventricular branch. And this is the LAD, and this is the marginal. This is the cardiac vein. It goes great cardiac vein. And also right atrium, mitral valve here. You can see this is the valve. And also atrium, left ventricle, And we are going down one by one. And RCA, again, LAD, this is around the fourth chamber, but this is oblique fourth chamber. It is not real chamber. What is the behind of this here, behind the heart? This is the esophagus, and also the ascending aorta. This is whatever you see, the huge vessel in the coronary region, it is the venous system. And all the around of the heart, we have to see the fat tissue like the black color. Not dark black, but dark gray, we can call it. It is normal. And around the heart tissue, always there is like a protection, like we can say cover. There is a fat. When fat is increased, this is another issue for the patient. Okay, this is the coronary sinuses coming from the pulmonary system and also cardiac, and going to the right atrium and then right ventricle, and then going to the pulmonary system again. Okay, this is the coronary sinus. All the carbon dioxide blood is coming to the coronary sinus. And the RCA is still running. And here is the marginal branch. You can see this is the long vessel, and LAD and RCA. And RCA is continue. And there is many vessels here. Big one is the venous, the another vessels, PDA and PLB. But which one is PDA and PLB? When we move it, there is a liver, RCA, ventricles, and stomach is here. And let me show you, RCA is coming like that. And the dividing two part. When you see any vessel, it is moving in between two ventricles, it calls posterior descending arteries. If there is any vessel moving to the little bit posterior and lateral part, this small part, you can see here, and this is venous, this is the posterior lateral branch, it calls. If the right dominancy, if there is a right dominancy, and always we have to see the PDA and PLB like this. If we see the PDA coming from the posterior part and moving here in this direction, and I hope you can see my mouse, if it is coming from the left side, it calls left dominant. Now you can see the PDA is better, and it is venous. And here is the biggest venous on the great cardiac vein on the left side. We should know the venous. If you don't know the venous, if you scan the patient late, and there will be contamination between the arteries and venous system, and you cannot make a decision which is the venous, which is the arterial, and only big venous system you should know, not the small one. Okay, and this is the left main here. This is LAD is moving this part, and then next to arteries, always there is a venous system. It calls great cardiac vein. And again, great cardiac vein, and then here it is the LAD, here is the diagonal, here is the CX, here is the right coronary system. Okay, the great cardiac vein is the traveling to the posterior part, and you can see the great cardiac vein and the posterior lateral vein is coming. You can see here it is coming like this in the fatty tissue, and this is the MIP images. It is showing better great cardiac vein and the posterior lateral vein, and again posterior and the great cardiac, and the great cardiac and posterior, and it is coming to reaching the coronary sinus. And also in 3D images, you can see the coronary sinuses here. This is the great cardiac vein. It is coming. And next one, there is a middle cardiac vein. It is coming from the next to PDA, traveling from the left side to right side, and it's coming and reaching the coronary sinus as well. All the venous is reaching the coronary sinus and coming to the inside of the right atrium. Okay, you can see here it's better.
Can you make it full screen, please?
Oh, sorry. Okay. And this is again middle cardiac vein and PDA, and left ventricular branch, it goes lateral ventricular branch as well. And it is showing very nicely. And middle cardiac vein, left ventricular branch, here you can see, and PDA is here, PLV is here. It is showing from the different perspective. This is the coronary arteries as a tree. When we remove the cardiac tissue, RCA and PDA and PLB is here, diagonal vessels, and the ramus intermedius, and the marginal branch, CX is going to the posterior part, and the left main arteries, and this is the aorta. And there is some septal vessel is coming, and there is acute marginal leaving from the RCA. Old vessel you can see in one shot, but it's not easy to understand because of the orientation. And always there is a two main vessel on the left side, it goes LAD and the circumflex artery. On the right side there is a big vessel RCA. Distal part of the RCA there is a PLB and PDA, and PDA is giving the dominancy. If it is coming from the right side, it is right dominant. If the PDA is coming from the and CX, big CX, and it goes left dominancy. And I guess that's all on my part. This is the basic anatomy. Please don't forget. If you need the future information, more information about the cardiac anatomy, maybe we can go to more detailed information, more detailed cardiac information near future. Thank you so much.